Thank you very much. I'd like to thank APAO as well as the AIOS as well as the Cornea Society that helped to arrange this particular symposium. So as we've heard in the previous several talks, diagnosis is one of the key components in trying to treat these patients with ocular surface disease, and specifically what we call dry eye disease as far as disclosures. So there are several things that we can do in terms of treatments after artificial tears or palliative treatments. One of the things to do before you start prescribing medications or doing other interventions is to try to eliminate things that are coincidental with ocular surface disease. For example, exacerbating medications, trying to eliminate such things that may dry the ocular surface. Cigarette smoking has been associated with ocular surface disease and dry eye. It apparently adversely affects the lipid layer and tear proteins. Humidifying ambient air and avoiding air drafts by using shields and by changing the characteristics of airflow at work, at home, or in the car may also be helpful. Lowering computer screens, as we know from Kazuo Sabota, there is a syndrome with computer screens, and trying to lower them below the level of the lid aperture, scheduling regular breaks, and increasing blink frequency may decrease the discomfort associated with computers and reading activities. Dry eye symptoms may have many contributory factors, and so sometimes when tear replacement is unsuccessful as the sole treatment, additional causative factors are not concomitantly addressed, and I think that is one of the key factors in unsuccessful treatment of dry eyes or ocular surface disease. As we heard from Professor Kinoshita, it is imperative to treat other causative things such as meibomian gland dysfunction and meibomitis, also to address lid malposition such as entropion, ectropion lag of thalamus, trichiasis, and other contributing medications, as was mentioned before. One of the medications, for example, in class of medications is antihistamine eye drops. This was a study done by Nevis et al. In non-dry eye patients. And with these antihistamines, even specific antihistamines, there can be drying effects. For example, in this study, they showed that keratitis, indicated by fluorescein staining, increased by 122%. Schirmer testing showed a mean decrease of 6.5 millimeters of wetting. Tear film breakup time was shortened by 53%. And there was an increased subjective ocular discomfort, again, in non-dry eye patients. So eliminating some causative medications may go a long way in helping these patients not only treat, but also potentially eliminate some of these symptoms. Another thing is to discuss realistic expectations for therapeutic goals. These must be discussed with the patients. I tell patients typically that you will not be cured because we really don't know the causative agents, and many times it is an age-associated as well as a gender-associated condition. And it's a very important aspect in the successful management of dry eyes, as many patients sometimes get frustrated and will move on to a separate or different clinician. And then the cycle begins again. There are many different excellent algorithms in terms of the treatment as well as the management of dry eyes. This was one of the first from the Delphi panel, Consensus for Dry Eye Management. This is a more simplistic version from ophthalmology, the dry eye, which I am a committee member of. So just to go through some of these that are, again, non-palliative, non-dry eye drops. The first is cyclosporin, topical cyclosporin 0.05%. It seems to change the unhealthy tears to healthy tears. It has been shown in clinical trials to increase tear production as well as goblet cell density by almost 200%. Corneal staining and blurred vision decreased in the clinical trials. And artificial tear use was decreased, suggesting improved patient comfort. There is good safety and tolerability for up to 4 years in the clinical trials, and moving forward, there's increased comfort and wear time for contact lens intolerant patients, and there are studies to show faster recovery and better outcome for dry eye patients undergoing LASIK surgery. This is from the FDA clinical trial showing that the results included the superior Schirmer scores in 15% of patients having over a 10 millimeter Schirmer score. So there was an improvement in Schirmer score by over 10 millimeters in 15% of the patients. Obviously, there were a fair number of patients who had a response that was not 10 millimeters, but 10 millimeters was chosen as the endpoint. The vehicle, there was only 5%. The vehicle actually was an excellent dry eye product. Topical steroids, they've been reported to decrease ocular irritation symptoms. They decrease corneal fluorescein staining and improve filamentary keratitis. In one study, a 2-week pretreatment of patients with a topical non-preserved corticosteroid before punctal occlusion was reported to reduce ocular irritation symptoms and corneal fluorescein staining. Lotoprednol etobenate 0.5% has been found to be beneficial in patients with keratoconjunctivitis sicca with at least a moderate inflammatory component. And then low-dose corticosteroid therapy can be used at infrequent intervals for short-term, for example, 2-week suppression of irritation secondary to inflammation. However, we must judiciously use them, as patients prescribed with corticosteroids for dry eyes should be monitored for increased intraocular pressure, corneal melting, and cataract formation. Omega-3 fatty acids, we'll hear a little bit more about antioxidants, but the use of systemic omega-3 fatty acid supplements for dry eye treatment has been reported to be potentially beneficial, but there have been few studies analyzing their efficacy. There was one double-masked study of 71 patients with mild to moderate dry eye syndrome demonstrating a non-statistically significant improvement in the Schirmer test, tear breakup test time, and fluorescein and lissamine green staining with oral administration of polyunsaturated fatty acids. Another study suggested that high dietary intake of omega-3 fatty acids is associated with a decreased risk of dry eye syndrome in women. But again, studies seem to be lacking. Nutritional supplements, over-the-counter fatty acid supplements, are non-regulated by the FDA. Their composition may be suspect, therefore. Dry eye patients taking linoleic plus or gamma linoleic acids and tablets have shown some improved symptoms, lissamine green staining, but there seems to be no effect on tear production or tear breakup time. And this may be a possible adjunctive therapy to the other dry eye treatments. Punctal occlusion, the goal obviously is to conserve tears by insertion of a semi-permanent or a collagen plug. They may decrease osmolarity and improve the symptoms. However, there have been studies to show that unhealthy tears may be trapped against the ocular surface. It has also been demonstrated to decrease tear production by using punctal occlusion. It only be effective really for aqueous tear deficiency. They have been shown to improve dry eye signs and symptoms. They are potentially removable if the patient develops symptoms of epiphora. One study showed that 56% of silicone plugs were retained after 2 years. However, in those patients whose plugs were spontaneously lost, 34% were reported to have canalicular stenosis at 2 years. Patients who benefit from having punctal plugs in place but spontaneously lose them may have lost the plugs or undergone permanent closure by their punctum by cautery or alternative means if the patients did benefit from the punctal plugs. If they're displaced, they may pass through the entire system. However, blockage with secondary infection has been reported, and although rare, surgical removal may be necessary, and therefore in the United States there has to be a discussion regarding the informed consent of punctal plugs. As far as other dry eye treatment, spectacle side shields and moisture chambers are non-invasive therapy. We saw a goggle treatment earlier for meibomian gland dysfunction. These glasses may be beneficial, however, typically they've been poorly tolerated because of the negative cosmetic effects. There are also moisture inserts, for example, Lacrocert. They're occasionally helpful for patients who are unable to use frequent artificial tears. Secretagogues such as pilocarpine and cevimeline, they're orally administered cholinergic agonists. They're labeled only really for treatment of salivary gland dysfunction, for example, Sjogren's disease. They do have some significant side effects. Clinical trials show limited improvement in dry eye symptoms. No increase in tear secretion has been demonstrated in clinical trials. However, topical ophthalmic secretagogues are currently under development. As far as these agents, most studies demonstrate great improvement in dry mouth. However, dry eye still has not been as significantly improved. Studies have shown that patients treated with pilocarpine at a dose of 5 milligrams orally 4 times a day experienced a significantly greater overall improvement in their ability to focus their eyes during reading and in symptoms of blurred vision compared with placebo-treated patients. The most common side effect from this medication was excessive sweating in over 40% of patients. Cevimeline is another oral cholinergic agent agonist that has been found to improve ocular irritation symptoms and aqueous tear production. It may have fewer side effects than oral pilocarpine. That's the agent that I prefer when using an oral agent for especially Sjogren's symptom. Autologous serum drops have been reported to improve ocular irritation symptoms as well as conjunctival and corneal dye staining in patients with Sjogren's syndrome and GVDH. It's been well documented in various different journals and is relatively simple to make. Filamentary keratitis has various different treatments. Number one, debridement must be done for the filaments. Typically, there's an application of some anesthetic and then debrided either with a cotton tip applicator or dry cellulose sponge or jeweler's forceps, which is my method. There are mucolytic agents such as acetylcysteine, 10% 4 times a day. Care must be taken to decrease and taper off of the acetylcysteine as mucin formation is beneficial for these patients. Soft contact lenses are effective in preventing recurrence of filamentary keratopathy but are poorly tolerated if the patient has severe dry eye. If the patient has associated neurotrophic keratopathy, contact lenses should be avoided. Finally, surgical treatment. The next symposium and session discusses more in depth the limbal stem cell failure and the surgical management, so this will not be covered here. A limited tarsorrhaphy can be performed to decrease tear evaporation in patients with severe dry eye who have not responded to other therapies. So in summary, eliminating exacerbating factors is typically the first step but often ignored. Lubricant, eye drops, gels, and ointments to try to eliminate benzalkonium chloride preservatives would be optimal. Anti-inflammatory agents such as topical cyclosporin and judicious use of topical steroids have been shown to improve patients' symptoms as well as their dry eyes. Punctal plugs, nutraceuticals, and limited tarsorrhaphy are those measures that we can use after the typical palliative artificial tears. Thank you very much.